be hearing about the Hillingdon Back to Health project. We know from many of our networking events and conversations with you guys around the country that working in partnership across communities is high on the agenda for many organisations, especially with the priorities that are soon going to be set out in the NHS 10-year plan. And for some time now, we've been working closely with the teams at Hillingdon Hospital and H for All. And H for All is a charity delivering community and wellbeing services across North West London. So we're really thrilled today to be showcasing the Hillingdon Back to Health project, which has seen partners working at a community level across areas of high deprivation in the area. The aim of the project, which you'll hear a lot more about in a minute, has been to help people on waiting lists for diagnosis and treatment, to help them wait well. So that can help to reduce pressure on healthcare services and build stronger connections within the community. So in a moment, we're going to hear from Sara Miles, who's my colleague, Programme Manager for Helpforce. We're then going to hear from Josh Thorpe, who's Project Development and Educational Services Manager at H for All. And then we're going to hear from Kate Crossan, another of my colleagues, and Kate is Senior Data Analyst from Helpforce. So Sara, first of all, is going to take us through the background and the design of the project. Josh is going to share his experiences of delivering the project on a day-to-day basis, and then Kate's going to show how the project has made an impact on not only patients but also volunteers and organisations in North West London. So we're going to have plenty of time for questions after the presentations. So please can we ask that you use the chat box for any questions that occur to you during the presentations, and then when we get to the Q&A slot, I'll round them up and try and make the best use of our time together. We've disabled your cameras temporarily while the presentations are going on, just to kind of reduce the strain on the network. But obviously, when it comes to the Q&A, you're welcome to turn your cameras on if you want to. So I hope that sounds okay. And I'm going to hand you over to Sara now. Morning, Sara.
Morning, everyone. Thank you very much for that intro, Sally. So before I get started and take you through some of the kind of development and the kind of why we did this project, you will hear quite a lot during this webinar around the relationship between the Trust, the Hillingdon Hospitals, and Hillingdon for All, the voluntary sector, and what worked well around the relationship and this project and working together. So just be really interested to understand from those on this webinar about your experience locally, anything you've done to date in terms of working between the voluntary sector and hospital trusts, how that's worked, successes and challenges. So just while I get started and start giving you some of the background, be great if you can just pop in the chat some of your experiences, if it's something that you already do and you have a relationship currently between the hospital and the voluntary sector, if it's something you've been looking at, if you've had any challenges, that'd be really interesting for us to understand as we go through. But as you're doing that, I will get started. So can I have the first slide, please, Sam? Brilliant. So as I'm sure many of us are aware of, missed appointments in the NHS are a big issue and something that we hear a lot about at the moment and have done for quite some time. And missed appointments are a challenge because they waste, a significant amount of time for clinics, staff time and staff resources. They increase waiting time potentially for other people, and for that individual who's missed their appointment, they are now going to have to wait longer for treatment and might see their kind of health decline during that time. We know that during 2021, 2022, some of the kind of latest data we have around missed appointments, there's about 7.5 million outpatient appointments missed. And often we know that they are, we talk about them being missed appointments and yes, they waste, clinic time and staff time. But we also know that often those appointments are missed for reasons that may be outside of patients' control. And often there are challenges around missed appointments that are linked to health inequalities. Reducing missed appointments, as we say, we know that it can mean that patients then are waiting longer to be seen, and trying to address this is a big part of the NHS's elective recovery plan and a big part of locally some of the conversations that are being had. So this was kind of very much some of the starting point of the conversations that we had with Hillingdon over 2 years ago. And what could we do to try and address some of that locally, and understand some of the reasons why locally people might be missing those appointments as well. We know that some of the reasons might be things like childcare or other caring demands, transport challenges, around work, potentially not being given the time off that they need to attend appointments. Maybe they've had a previous poor experience with that area, with that trust, and so there are kind of challenges, and people are anxious about attending. We also know that people sometimes attend their appointment, but that those appointments aren't able to go ahead because perhaps they haven't fully understood what they needed to do ahead of that appointment. So if they've received a letter and it's told them that they need to take medication or not take medication or do something specific ahead of that appointment, if they haven't fully understood that, they attend that appointment, they haven't done what's needed, then that appointment might not be able to go ahead. So again, for everyone, time has been taken out, that clinic slot's been allocated, and that appointment can't go ahead and be successful. So also we were considering the ways that we might be able to address that and make sure that when people do attend their appointments, that appointment will definitely be able to go ahead as much as we kind of with anyone's control. So when we started these conversations a number of years ago with Hillingdon, we got lots of the local stakeholders together to understand, what could we do, what might work, who could be involved. And what we were looking at was some really supportive reminder calls, where we could have some really good conversations with patients, not only remind them their appointment, make sure they knew what they need to do ahead of that appointment, but also kind of try to elicit if there were any concerns they had, any concerns about the appointment, any concerns about how they were going to get there or anything like that, and just make it as easy as possible for people. We know that people might be anxious ahead of an appointment. So how can we, what can we do to help reduce some of that? And if they know where they're going, maybe where they can park, or actually that they need to get public transport and how to do that, then, that might just help to alleviate some of that kind of anxiety and some of that stress on the day. Next slide, please, Sam. Brilliant. So looking at the service that we developed, so Hillingdon for All, who are like a local brand of the third sector together in Northwest London, were identified as a voluntary partner right at the beginning of this project, and were involved from day one in terms of scoping it and getting the funding for the project and everything like that. And as we got into the project, they've been responsible for the day-to-day and everything that's going on around recruiting the volunteers, managing the volunteers, delivering that service on a day-to-day basis, getting these calls happening. The Hillingdon Hospital were then the clinical partner, and so they've made sure that they have been able to kind of collate lists of people for the volunteers to call, and they've also had a clinical lead involved who's been able to give advice and support and follow up with patients where there were any particular concerns. At Helpforce, we've been involved from the beginning to help scope the project and look at what the service might actually be. And we've also evaluated the project, and my colleague Kate will take you through that evaluation later on. For this project, we decided initially to focus on one particular area within Hillingdon. So we honed in on Colne Union, which was an area of fairly high deprivation and fairly high health inequality. And by honing in on that kind of one area, it means that during the evaluation, then Kate's been able to compare what's been going on in Colne Union to the other PCN areas in Hillingdon, which has been really helpful. And it's been a very data-focused and data-driven approach to this project. So right at the beginning, we identified that we would, the calls weren't just going to be to everyone and anyone that might have an appointment within Hillingdon Hospital, but actually that we wanted to identify the areas where there was a really high volume of missed appointments and where we thought we could make a real difference. And so looking through the data, looking at those do not attend rates and looking where those appointments were being missed, but where there was also a large number of appointments each month and a lot of calls that could be made, we identified that ophthalmology would be the focus for the project. So patients that were having appointments coming up within ophthalmology, where we could have these calls made to them. And ophthalmology is one of those areas where there is some things within a letter that patients will be told, and where that's not always fully understood. So whether you're going to have drops put in your eyes and whether you will or won't be able to drive home after an appointment was, potentially a bit of a grey area. So being able to make sure the volunteers could really, talk people through, and be, make sure that people weren't going to drive if they then weren't going to be able to drive home. And so really what we've been looking at is whether we could reduce the number of missed appointments that are happening within ophthalmology, within Colne Union, compared to other specialities and other areas within Hillingdon. If you could go to the next slide. Thank you, Sam. And you'll hear from both Josh and Kate in a moment around some of the successes and some of what we found in case studies and some of the data that we've now been able to analyse. But there's been a number of key things which have felt like they've made this project a real success. One of the things is the engagement we've had from stakeholders across voluntary sector, across Colne Union PCN, from pharmacists and others involved. We've had really great engagement from the hospital, and everyone has really been focused on, if there have been challenges, what can we do to troubleshoot and make this work. Some of the other successes have been around the fact that it's been very local, so that where the volunteers there have been kind of support needed, that they're able to signpost to local services, some of those services being other services that H4All support and operate, so being able to have a really kind of seamless way to do that. And being volunteer led, they've really been able to give that personal call where, some of those calls will be very quick, but where people have needed to talk for a little bit longer, they've had that time and they've been able to have that personal approach to things. And where possible, we have tried to keep things as simple as possible for everyone involved. So we've, developed pathways, and Josh will talk you through just in a minute about the service and day-to-day how it's worked to try and make things as simple as possible, to try and make sure that everyone involved knows what their part of the picture has been as well. So I'm going to hand you over now to Josh, who's going to talk you through more kind of on a day-to-day basis what H4All did, and around the engagement with the trust.
Thanks. So hi everyone, my name is Josh Thorpe. I'm the Project Development and Education Services Manager for H4All. So I was involved in the day-to-day management of the project, as well as the oversight of the project as well. So on a day-to-day basis, what it really looked like was we would get the data from the hospital of a list of the ophthalmology patients. So at first, these were agreed to send every 2 weeks, but then we found it was not really time efficient doing that. So we got them sent to us once a month, which proved proved the sweet spot really. And this would provide us with the appointments for the patients within that month, so we could call them. So the coordinator would generally arrange for the volunteers to come in around 3 to 4 days per week. They would do a couple of hours each, and the coordinator would also make calls. They had a set script that they would go from, and any problems we would note them down on a separate sheet of paper and then the coordinator would then fill out a master spreadsheet of all the calls made, as well as documenting whether they were passed on to the clinical lead, whether they needed a call back from a member of staff, so one of us, or whether they were completely fine with their appointment. At every stage, the volunteers were feeding back comments to the coordinator, and this in turn, the coordinator would coordinate with the clinical lead, Amar, at the hospital for any problems. I think the coordination between ourselves and Amar was crucial, as it allowed us just to bypass any of the kind of the tape you get when you've when you tried to call through to the hospital, where we could rebook the patients quite quickly, and we could also sort out any clinical issues. Well, a marker to sort out any clinical issues very, very quickly. Next slide. So from these calls, and what made it so good is from the script, we had kind of light probing questions where where the coordinator could identify whether there was any other needs aside from their main condition. So we have 2 case studies that were presented that came from patients who at the time were just having a general conversation with the coordinator. So this first case study is around a patient experiencing frequent migraines and headaches related to her eye condition. So from there, the volunteers let the coordinator know, and the coordinator then passed on the details to the clinical need for a further assessment and then a management of the symptoms. So the patient themselves was from India. They initially moved. For marital reasons, and quite quickly became a victim of domestic abuse. She had no leave to remain in the UK, so it prevented her from accessing any benefits. She was very dependent on food banks and living with a family friend in a spare room. And she also cared for her 4-year-old daughter while dealing with depression because of the circumstances. So she was telling the volunteer that the daughter attends nursery for 3 hours daily, and was receiving counselling from Home Start, and she was regularly accessing the food parcels from the food bank. So all of this was coming out from just a light probing conversation, and the volunteers were trained to kind of deal with these. And when this conversation became apparent that it was a domestic abuse case, they were trained to pass this on to the coordinator. And what we were able to do is we flagged the concerns. The coordinator then followed up to gather more details from the person, and we then signposted and shared and referred into a domestic violence charity, and we also got her legal advice for immigration support, and we arranged for that referral to the legal charity as the patient was unable to reach out herself. So this was the first and a perfect case of wider problems that were identified just from a simple conversation. Can we move on to the next case study? So this one was a patient. So a patient where she'd had a fall and spent some time in the hospital because of it. So the initial conversation wasn't with the patient themselves, it was with the daughter, and the daughter expressed concerns over the phone about whether he was well enough for the upcoming injection for the appointment. So the daughter was unsure whether to reschedule or bring him in for a checkup, and the clinical lead was contacted by the coordinator shortly after this call for some guidance and next steps. So the daughter explained to the coordinator that they had initially had difficulty booking a GP appointment for a post-fall checkup, and from there, the coordinator also offered in addition to contacting the clinical lead at the hospital, to also contact the GP surgery on the behalf of the daughter to arrange a callback. So the daughter also shared that she had taken a significant caring role for both her elderly parents, so not just the falls victim. And from there, it was identified that, okay, well, we can make a referral from Carers Trust to get her the kind of help the daughter needs, but also get the help that her parents needs as well. And we arranged help applying for a blue badge for her dad. So the kind of outcomes from that call was the clinical lead at the hospital was able to advise whether to proceed with the appointment or to reschedule. The GP surgery contacted the patient as well for a checkup, and the referral was made from Carers Trust, and this resulted in the daughter getting a blue badge for her father as well. So again, just from simple conversations, lightly probing, going through the script, we were able to identify wider issues that may not have actually been ever picked up if it was not for this call. So next slide, please. So the insights from the clinical lead actions. So as I said before, whenever we called a patient, we would go through the script, and when they would say to us different reasons why they could not attend their appointment or why they would need to reschedule, this would be noted down by the volunteer and then reported to the coordinator, which would then, if needed, be reported onto the clinical lead. We can see here that 110 of the clinical lead actions taken was a change of appointment in date and time. I always felt throughout this whole thing that a change of appointment date and time is such a simple thing, but it was surprising how many people were not able to get through to the hospital to actually do this. So having the clinical lead there just to bypass that call, the patient waiting in line or not even being responded to by the hospital, it allowed them to feel like it was actually like a personal service. And it allows them to change their appointment in like 5 minutes rather than waiting days or even weeks. The next one is around 86 of them were answering queries about appointments. So this range in a different things, like really, really simple stuff. A lot of the time, the coordinator could answer these questions of, is there a bus stop nearby? What's the parking situation? Like that kind of thing. But the clinical lead was also able to answer more in-depth questions around what exactly happens at appointments as well. And then as we go down the list, we see that the clinical lead actions was responding to concerns about their eyes, sending, requesting appointment letters and texts. That was another big thing where we spoke to the ophthalmology team at Hillingdon Hospital around patients not receiving letters or receiving texts, even though the patient specifically requested a physical letter. And it was also identified there that there was a system error where these texts were being sent out regardless if the patient had put down whether they had put if they needed a physical letter. We also looked over the literature that they were sending, and working with the ophthalmology team, we actually reduced the amount of unnecessary information to put on the letter, really specific bullet points, so patients were able to read it a lot clearer. So again, like going down the list, the other ones was confirming appointments, flagging incorrect phone numbers, emailing to other specialists, changing the appointment from Hillingdon Hospital, often going to Mount Vernon, or contacting the eye care liaison officer. There's a few cases where a patient has passed away and a few cases where we needed translators. Next slide, please. So with these ones, you can see there's a few stories from the clinical lead. The thing that I've taken from there and what she has fed back to us is she actually felt that she was semi-retired anyway, and she felt a lot closer to patients through this project than she did when she was actually seeing them in the hospital. So going through there, she was actually feeling like the patients were getting more of a service very quickly. And from these clinical lead stories here, you can see there's a range of different issues that she was able to sort. So I'll pass you on to, I think it's Kate next.
Yes.
Great, thank you.
Sorry, Josh, I was too slow there. But yes, it's over to Kate now to take us through the evaluation. Thanks, Kate.
Thank you. Thanks. Just to give you a bit of background, so at Helpforce, when we come to evaluate any projects that we've worked on, we use a consistent methodology to determine what the impact of volunteering roles on health and wellbeing has been. So what we do to start with is we identify what the target outcomes are across a range of beneficiaries of the project, and then we design data collection methods to prove and evidence those outcomes, collect the data, and then present back findings to you, similar to what I'm doing today. So some of the outcomes that we were seeking to prove from this evaluation were things like, for patients, them being as prepared as possible for their appointments by removing barriers to care and being more informed about their care. For the organisation, having a reduction in the do not attend rates, the DNA rate, amongst patients that have upcoming appointments. And then for volunteers, things like improve confidence, developing new skills and confidence at the time that they're spending volunteering is of benefit to others. And to do that, we use 4 different data collection methods. So we put in place a call tracker that Josh has already mentioned, and that monitored for each patient that the volunteers attempted to call, whether the patient took part in the call, any concerns that were raised during it, and any actions that were taken as a result. We had an online volunteer survey that was conducted twice, so once about 4 months into the project to understand initial kind of feedback from the volunteers, and then again at the point of evaluation. We completed a semi-structured interview with the clinical lead just to gather some of her feedback on how she felt the project had gone and the impact that she felt like it was having. And then finally, we got access to data from the Hillingdon hospitals, and that was on those DNA rates within the target group, so within Colne Union PCN, but also within other PCNs, so that we could compare and contrast what had happened. Next slide, please. Thank you. So looking at the actual calls, so between December 2023 and January of this year, the volunteers attempted to contact 2,263 patients, and overall they managed to engage with 2/3 of those patients, so 67% overall. And when we look at that across the year, so the volume of successful calls was quite low in December and January when the project first started. And that was to do with some things around making sure everything was in place around data sharing and everything like that. And then after that, the calls ramped up. They did dip again in the summer months, and that was due to the coordinator having to take some unexpected leave, and then she left her position, which just goes to show the importance of that coordinator role and being in place to support the volunteers and them undertaking their work in this project. But then a new coordinator was allocated to the project, and that resulted in at least 140 successful calls being achieved every month from October. And that was there was an all-time high in November of 353 total successful calls. When we talk about successful calls, we're talking about people that volunteers have managed to get on the phone, so they've actually answered the call, and then that they've consented to continue with the call. The majority of unsuccessful calls were just due to the volunteer not being able to get through to the patient, so whether that was that the patient wasn't picking up, they were only getting their voicemail, or they had an incorrect number for the patient. So out of the over 1,500 patients that the volunteers actually managed to get through to on the phone, only 15 of them didn't consent to continue with the call. So it was really positive to see that the vast majority of patients were very happy to have that phone call with the volunteer. Next slide, please. So the majority of patients that volunteers spoke to still needed their appointments with ophthalmology, and they were able to attend at the scheduled time. But there were 221 patients that volunteers identified for whom that was not the case. So either they didn't need their appointment anymore for whatever reason, or that they couldn't attend at the time that they'd been given. So without that intervention from the volunteer, that might have resulted in those appointments being wasted, or in patients being recorded as having not attended, which we know leads to risks of people being actually discharged from services if they have repeated non-attendances. Barriers to being able to attend the appointment were recorded if they were mentioned by the patients through that supportive conversation that Josh was talking about. And the barriers were relatively evenly split between those who still needed and were able to attend their appointment, and those who weren't able to attend for whatever reason. But the actual kind of barriers were different for those two groups. So personal and work obligations were more likely to be mentioned by those who couldn't attend their appointment, whereas those who would be attending their appointment were more likely to mention things like transport and accessibility issues. And that then enabled action to be taken to support their attendance at those appointments. So whether that was things like providing directions or the clinical lead double checking that transportation had been booked for them. Again, it was highlighting things that might have prevented their attendance and being able to support them through that instead. And then in terms of the actions that were taken, so 3/4 of the successful calls resulted in some kind of action being taken. And in the vast majority of cases, the most common action that was taken was the volunteer just providing or reminding the patient of their appointment details. But others were also given vital information to facilitate the appointment going ahead. So like Sara mentioned at the start, there were some procedures that might take place at the appointment, which would mean that the patient couldn't drive afterwards, or that it might be helpful if they have somebody with them to support them, for example, getting home via public transport. So volunteers were able to give that kind of advice as well, to ensure that even if they did attend the appointment, that it could go ahead as planned with any procedures. We had 28 patients as well who were signposted or referred to community support. So that goes to show again that the supportive conversations that the volunteers were having was eliciting information about things that went beyond just the patient's ophthalmology appointment and their eye health. They were identifying things that were to do with their wider well-being. So some of the places that they were being referred to were things like places like Carers Trust and being referred back into H4All, so for some of their health workshops or to their triage, and places like Carers UK and Age UK and Dash. And just under 1/3 of patients needed a staff member to follow up, which in most cases was the named clinical lead for the project. But as Josh said as well, there were some things that the coordinator was able to support with as well. So moving on to the organisational impact that was seen from the project. So the key thing that we were looking at for the organisation was the impact on the do not attend rates for the for ophthalmology. And what we saw was for ophthalmology, for colon union patients, so the ones that were being targeted with the calls, the DNA rate decreased from 13.2% in the year before the calls were made to 11.2% since the calls have been made. So that represents a 15% relative reduction in the overall DNA rate, which is a statistically significant change. So we can see in the chart there that there were notably high DNA rates in sort of November, December 2023, and around the same time there were lower numbers of appointments in those months, which might have been causing that spike in the DNA rate, and that might be affecting this comparison to some extent. But what we did see when we looked at the data was that there was a similar dip in appointment numbers in December 2024 without that spike in the DNA rate. So that was a positive to see. And when we looked at the DNA rate for patients in other PCNs, so not the outside of colon union, there was a reduction during that time in the DNA rate, but to not the same extent as was seen in colon union PCN. So they saw a 4% relative reduction in their DNA rate compared to a 15% one in colon union, which is really positive. And then, as Sara mentioned, we wanted to look as well at the impacts that might have been had on people living in areas of higher deprivation, because we know that those people are at higher risk of experiencing health inequalities. So to do that, we looked at the do not attend data from a deprivation perspective using the English Indices of Multiple Deprivation, or IMD. So for those of you that have not come across the IMD before, what the IMD does is it allocates small areas of England a number between 1 and 10, otherwise known as a decile, and the lower that number is, the more deprived that area is considered to be. So for this analysis, we use slightly larger groupings from 1 to 5, which we call quintiles, but with the same principle. So 1 represents the most deprived areas in the country, while 5 represents the least deprived areas. And we looked at that within Colne Union for ophthalmology appointments. So what you'll see on the left is for the light blue bars, that shows you what the DNA rate was for each of the different quintiles for ophthalmology in Colne Union. So you can see there that the higher the level of deprivation that the patient lived in, the higher the DNA rate tended to be, so the less likely they were to attend their appointment. And that felt like it was a really clear trend that was there. And then the reddish pink blocks show what it was after the volunteer intervention or during the volunteer intervention. And what we see is more of a flattening of that. So it's a less kind of clear downward trend that's there. So quintiles 1 and 2 have a very similar DNA rate following the volunteer intervention, and quintiles 3 and 4 have a very similar DNA rate following that. So there's been more of a flattening of that discrepancy. And that's reflected as well in the chart that's on the right, which shows what the relative reduction in the DNA rate was for each of those deprivation quintiles. And you can see that the highest relative reduction in DNA rate was for those living in quintile 1, so the most deprived areas within Colne Union. So it appears like this implies that there's been a positive impact on those living in the most deprived areas, and therefore those that are at the highest risk of health inequalities. One of the other key groups that we wanted to see what impacts the project had on was volunteers. Feedback from volunteers about their role was really positive. I won't go through all of these, but just to pick out a few key stats. So 12 of 13 felt like their volunteering gives them a sense of purpose. All of the ones that we surveyed felt that they'd received enough support from staff members and that they had all the equipment that they needed. And 12 out of the 13 agreed that their volunteering has a positive impact for patients and a positive impact for the organisation. So really, really positive things to hear. And on the next slide, this positivity just continues, really. So all the volunteers that we surveyed were satisfied or very satisfied with their role. They all felt like their role had met or exceeded their expectations. And comments from the volunteers included things like feeling supported in their role, that they'd already recommended the role to other people, and feeling that what they were doing was making a difference both to themselves and to the patients that they were speaking to. So just to sum up some of the key points from the evaluation, so what we saw was that sizable volumes of volunteer calls were being made. There were those 221 patients that were identified who couldn't make their appointment for whatever reason, which may otherwise have led to wastage of those appointments. Volunteers were also able to provide key information to patients to facilitate their appointments going ahead as planned. But beyond that, support for patients' wider health and wellbeing concerns were also able to be addressed either by the clinical lead or by the coordinator at H4All. We saw a relative reduction of 15% in the DNA rates for Colne Union PCN patients, and there appeared to be a positive impact on those at risk of health inequalities, with the highest relative reduction in the DNA rate being for those in the most deprived areas. And really positive feedback was received from volunteers about their role in terms of satisfaction, having their expectations met, and the impact on them and others. So that's everything for the evaluation part. So this report is really hot off the press, to be honest. So it's not yet published on Helpforce's website. We're hoping it will be published soon and will feature in the April Helpforce newsletter. So we'd encourage you to join our mailing list if you'd like to read it in full. Debbie's just posted the link for you to do that in the chat. So you would be you'd get a notification through our newsletter once that full report is published if you're interested in reading it. I'll hand back to Sal.
Thank you, Kate, and thanks to Josh and Sarah as well for taking us through that in such amazing detail, and really great to hear about the success of the project. So we do have some questions in the chat box, which I'll run through. I know a number of them have been answered already, so thank you guys who have been presenting for answering those for us. We have a question from Amy, who's asked if the call script could be shared. Josh, is that something that is possible to do?
Yeah, that's no problem.
Okay, that's brilliant. That's great. So, and then we've got another question from Lucy asking about the data. So, Kate, do the figures refer to individuals or multiple calls to the same individual?
So if the call was regarding one appointment and there were multiple calls to that patient to kind of either try to contact them again, that counted as one patient. But obviously there might have been the same patient contacted multiple times if they had multiple appointments during that time. So the same patient might feature a couple of times in the data if that was the case.
Brilliant, thanks, Kate. Just had another one from Nia in the chat box. Can you share the volunteering role description for the opportunity? Is that, Josh, is that something you'd be able to share as well?
I'll have to ask, but it shouldn't be a problem.
Okay, brilliant, thank you. So question from Paul. So what led to this happening? Yeah. What was I think Sarah, you sort of covered that in your area of the presentation. So what were the drivers for the project? And then there's some follow-up questions in there as well. So if we could start with what led to the project happening.
Yeah, so like I said, we kind of started on these conversations probably over 2 years ago now, and they were with the Integrated Care Board and with their Health Inequalities team, and it was something that they were really interested in and something that Helpforce had started looking at some of these calls with another trust we were working with, which was George Eliot. So we'd had some experience of doing it. We were seeing some kind of positives there and some successes, as you know, and there's others kind of bits running elsewhere as well. And so we picked up these conversations with the ICB, who were really keen on it and provided some initial funding for this to be able to run as a pilot. And what we've got now, having kind of run this, and you know, Hillingdon managed to run theirs for about 18 months, kind of to have those calls, is obviously the evaluation and the insights and the kind of evidence, everything, but also all the assets that have been developed, like the call script, like the training package for volunteers, all the lessons learned about what worked well and what didn't, which we are kind of packaging up to enable the ICB across Northwest London to look at kind of expanding that further. And internally, you know, with the Helpforce, we've developed and packaged a lot of that up over time as well for other people that are interested in speaking to us and looking at something similar as well. Because I mean, I completely agree. There is, you know, it's some of the setup of it. You know, we came across a few challenges. We had a couple of data kind of sharing issues and a couple of bits that needed to be worked through, but you know, now we've gone through all of that. You know, it is, you know, as a business as usual project, it's really kind of you know, it should be kind of really easy to keep going and to be able to do. And you know, once you're in the swing of it, you know, the volunteers, you know, Josh was talking about before we, you know, got on the call, we've got such a great group of volunteers. They've, you know, managed to get together who have, you know, really given so much to this project as well.
Thanks, Sarah. And just following on from that, Paul's asked who were the volunteers? How inclusive was the recruitment process? Is that something you'd be able to comment on, Josh?
So the volunteers themselves were picked actually from another project we're doing called Compassionate Hillingdon. So they previously made, so the original 5 volunteers, sorry, were from Compassionate Hillingdon. So they made befriending calls. So they were approached whether they wanted to do this. and they jumped at the chance because they just liked talking with people, and it was a good use of their time. And then the other ones that were recruited after that, they go through a process of being identified from the volunteer team, which is separate from me, and then they are sent to me based on set criteria. So um, they could be wanting to get experience in admin jobs for future employment, or just wanting to fill their time, really. So that's how we narrow it down.
Okay, thank you, Josh. And then Heather, in a similar vein, what training was given to the volunteers to help them advise on other community support that's available, and how did you provide that training?
So the training themselves was provided by myself and the coordinator. So I'll answer it in two parts. So the actual training program was developed by us, and it was around less talking information and more like scenario play. So I would pretend to be the patient, and we would go through the set script, and they would go through it. In terms of the signposting material, H4 is in a fortunate position where we're part of a wider family of charities, such as Harlington Hospice, Carers Trust, that type of thing. And so what we would do is go through with the volunteers the kind of signposting opportunities that are around Hillingdon, and that would also be built in with the kind of role play as well. But when we would go through, so for example, the role play would include if identifying a potential person who's a carer. If they identify that, making sure they ask, are you getting your carers allowance? Are you signed up to Carers Trust Hillingdon? That kind of thing. So going through that, if there's something that the volunteers didn't know while they were on the call, the coordinator was always around to answer that question. And if the coordinator didn't know, they would come to me and it would be addressed.
Brilliant, thanks, Josh. Another operational question from Lucy. Do you use a volunteering app or system for making the calls and for allowing reports to be operated?
No.
So that's the first question. No. Okay.
So the calls were made from landlines. So we did initially try having multiple volunteers in at a time, but it just got too busy. So they would come in one at a time for a few hours. There would be a landline in there. The coordinator would then sit in, and we found that some volunteers kind of IT skills were very varied. So instead of them using a laptop or anything, we had a set kind of template on paper that they would go through, and then the coordinator would quickly enter that after each call.
Okay, great, thank you. And part two of Lucy's question, have you made use of volunteers in the private sector, an employer given volunteering time?
So that is a really good question. So I will try and answer this best way I can. For this type of project, I don't think it's appropriate. I think the type of people that we kind of got for the volunteering were like really hyper local people needing experience rather than professionals. And I just don't think they would have really got much out of it. And I don't think, with all respect to them, they wouldn't have the empathy. So the people that we got on this project really had an interest in changing services, but we haven't. But no, not for this project. But we have utilised professional ones in the past.
Great, thanks, Josh. Miriam asked a question about equipment provided for volunteers. Sarah, you've actually answered that, I think, haven't you?
I think so, unless I think that's correct, unless Josh tells me otherwise. But I think, it was from all the calls are from H4's offices. I think you mentioned. So I think at the beginning you had to secure another line or a couple of phones, didn't you, Josh? But yeah.
Once that was set up, it was a relatively low cost, to be honest. But yeah, once that was set up, it was fine.
Thank you. And questions from Nancy. I'm really interested to in how you managed to share. Can you explain what you mean by, do you mean
personally identifiable data?
Okay, thank you.
Yeah. Sorry, NHS speak there.
So did you have a list of identified providers? Did you have any checks on these providers before making patient referrals? Do you have an SLA?
So,
and then another question, there's a follow-up question, we'll deal with that separately.
So yeah, we went through the whole of this with the data sharing agreement and all of that. So Hillingdon's in a quite unique position where we have a wider data sharing agreement between our collaborative, which is Hillingdon Healthcare Partners, or HHCP as people call it. So HHCP refers to a group of organisations which H4 are part of, but it also includes GP surgeries, Hillingdon Hospital, which is our partner, the ICB, and a lot of other charitable organisations as well as health organisations. So we have a overarching data sharing agreement where we can share data between ourselves, and that's what did cover us. And I think, as Kate and Sarah spoke to before, that's what we really nailed down within the first 2 months to make sure that that was in place. It's also, it goes without saying that once the data comes to us, it was never shared outside. It was only between Hillingdon hospitals and ourselves, and it was going back and forth, but no outside organisation were sent that data, including Helpforce. It was all anonymised.
Great, thank you, Josh.
I was just going to say, Sal, although Hillingdon were in a very a position I don't think we found anyone else in before, in terms of they already had done a lot of this work and had some of these agreements with the trust and others locally. We have been doing a similar project with Brent, another area in northwest London, who didn't have that agreement, but we have managed to support the trust and the voluntary sector, CVS Brent, to put that in place. So they have a very similar project with the voluntary sector making calls as well, and we have managed to kind of support to make that happen.
Great, thank you. Nancy, you've got your hand up. Do you want to come in there?
Yeah, I was just going to say, I think that's absolutely critical for any of the work that we do with the voluntary sector. And because there is this big movement from sort of treatment to prevention, and how we work much more collaboratively with the voluntary sector, that is really interesting, because there's so many restrictions around GDPR, data sharing, etc., etc. So I don't know how that can be shared wider, more broadly with other ICBs, and how that might look nationally rather than, because I think that's key, that's critical.
Yeah, 100%. I mean, as I said before, like Hillingdon is unique, and I very much realise that we are very lucky with the position that we have with the overarching data sharing agreement and the kind of relationships that we have. I think throughout that project, I mean, Kate and Sarah can both say, like, without our relationship with Noel, who provided us with the data at the hospital, it wouldn't have been so successful. So I think it is key to have those relationships, and from when it was operating in Brent, you can see that if those relationships are not in place, it does take a little bit to get off the ground. And as well, you need to have the buy-in from the hospital as well. So yeah, definitely. Great,
thanks, Josh and Sarah. Nancy's also put a question in about language skills. Did you seek out specific language skills from volunteers at all, or tap into them?
Yeah, so there wasn't as many language barriers as you may think. So a lot of the people there, a lot of people could speak English, and because that was one of the things that when we were setting this up, we spoke to the staff as well at ophthalmology and said, do you get a lot of people who can't speak English when they come to their appointment? And surprisingly, they all said they had a competency of English where they didn't need an interpreter. So, but we did have volunteers there who could speak a number of languages, so Hindi, Gujarati, and there was and Punjabi as well.
And it's worth saying on that as well, in other projects that we've worked on that are similar to this, it's been a similar kind of story where we've had maybe fewer instances where we've identified that somebody would need an interpreter either for the phone call or for the appointment that we're calling about. So it's not completely clear across all those different projects whether it's that those people who do have those language barriers are potentially more difficult to reach via the phone, or whether it's for another reason. But yeah, that's definitely not something that's been unique to Hillingdon. We have seen it in other projects as well.
Thanks, Kate. Thank you. Paul has asked a question about volunteer turnover across the project.
So extremely low, if I'm honest. And this goes into why we didn't recruit kind of from professional organisations for volunteering, is we needed volunteers who would be in it for the long haul, really. And because the volunteers going forward, even though this has stopped now, they're still very much a part of other projects within HRAW. So we did, and that goes into choosing them as well to make sure they have an interest in volunteering.
Thank you. And then one final one at the moment from Lucy. You mentioned some funding from the ICB. Lucy's wondering what other funding arrangements going forward beyond the pilot period.
Great question.
We would love to know as well if anyone else can answer that. So I think the ICB do recognise, I'll answer it in two parts. The ICB do recognise it is a good piece of work. I feel that no arrangements are currently in place, but I feel after this report comes out that may change. There are a lot of conversations between say Hillingdon Hospital putting in some funding arrangements around health inequality transformation funding, where they've spoken to me about using this model. I know that Public Health in Hillingdon are interested in using this model as well for cancer screening. So there is a lot of conversations going around in terms of funding this specific one going forward. I hope in the very near future that we can carry this on, because now it's set up, we would need very little funding, and it is a great project and the volunteers enjoy it as well as the clinical leads, but nothing has been set in stone, unfortunately.
Okay, thanks, Josh. And then one more from Paul around exit strategy from the project. How did you manage that?
Very gracefully. So the agreement with Hillingdon Hospital was always and between all of us, we always knew that this would come to an end at the end of the financial year. That's how long the funding was in place for. So there was always that conversation of like, that's the cut off. But the way we've left it at the moment is we've said before to Hillingdon Hospital, they're trying to put in some health inequality transformation funding to carry it on. But the way we've left it at the moment is the volunteers have moved on. Our coordinator has also moved on to another project, and so like, but that's my job. But yeah, I hope, as I said, hopefully in the future we will carry it on, because THH really do value it, and I don't think it will take a lot to pick it back up.
Brilliant, thank you. Okay, I think we've got through all of the questions in the chat box. Yes, and thank you for the feedback, Paul. That's great. Thank you all for your presentations. Special thank you to you, Josh, for